Hello, everyone, and welcome to Your Healthy Dose with Kim Douglas, a podcast about current trends in healthcare. And today's topic is preventative care and health screenings. And I'm very happy to have here with me Dr. Mark Needham. And Dr. Needham is a family doctor with Santa Monica Family Physicians and St. John's Health Center. Welcome, Dr. Needham.
Thanks very much. Good to be here.
I'm so glad you're here. When I knew that I was going to be interviewing you, I was thinking about this and I thought, many people think the glamour of being a doctor is like saving someone in the throes of a serious disease or a big injury. But what about the importance of just prevention?
The workaday world of primary care and preventive care is we would just as soon people don't get sick, don't need surgery, don't get cancer. And so we do a lot of the what you describe as preventive care to keep out of the limelight, keep the patients out of the limelight. Looking across the street at the hospital, we would just as soon let them not go.
Exactly. Well, why is it important to have a primary care physician?
Well, there's a lot of things that happen sort of over somebody's lifetime that we can, if we know about early, if we can make an intervention early, they're long term, they will benefit by having hopefully maybe less diseases, or even if they do get diseases, we can intervene on them before they become more serious. And so having somebody kind of watch out for that is different than what we would call episodic care. So this morning I did urgent care. That's part of our primary care practice. But that's the opposite of preventive care. That's, people falling off their bird scooters, crashing their bikes. But it's episodic care, and it's not where we would spend our time focusing on making sure that women had breast cancer screening, cervical cancer screening, make sure we checked our blood pressure, we'll see that. But making sure that their immunizations are up to date. And so those sorts of things are really done much better in the setting of a regular visits with a primary care physician who knows you and actually keeps track of it.
That's right. Absolutely. So important. So what do you think St. John's team approach to health care is? And what is population health?
That's somewhat a new term,
an
old concept. But So think of my practice, Santa Monica Family Physicians, as part of a larger group, St. John's Physician Partners, and it's part of this larger health center. So we have electronic medical record where the 220 physicians, we all see that together. And so it's a team effort from that standpoint that we all build on each other's knowledge base, notes, and so forth. But one of the things that that electronic medical record can do is it keeps track of the screenings that we think are age appropriate for our patients, and say, using cervical cancer, breast cancer, colon cancer as examples. So there's 10 or so of those different types of screenings that we keep track of. And so when a patient comes in, the electronic medical record will pop up reminders about, it seems like you're due for your pneumonia vaccine, or you're due for your HPV vaccine if you're an adolescent, or even now it's an older age group for that. But then what that does is then we keep a database of I think we must have 40 or 50,000 patients in the database that we track for preventive care. And so we have, I guess that would be what was called population health. We have a group of data analysts and an outreach team that looks at that, and so we know to the exact person each year who's hasn't been in for a colon cancer screening, whose blood pressure is out of range. If they're diabetic, we know if it's called an A1C, it's a monitoring test for their degree of diabetic control. We know them all. I don't know them personally, but we know them as a population. And so our outreach team can call those patients, send them letters. For example, once a year, we'll usually send patients who have not had colon cancer screening, we'll send them a diagnostic stool kit for them. A lot of people don't want to get colonoscopies, and that's been a problem during COVID, is that they haven't wanted to go for colon cancer screening in person. So we send them the stool testing kit. They put some poop on it and send it to the lab. And then if they're positive for blood in there, then we twist our arms to get a colonoscopy. But that's sort of what population health is. So we keep track of the percentages, and so I think it works too, because we're really proud of this at St. John's. I think that for the 10 metrics that we follow, I think that we're probably well ahead of the other foundations in Los Angeles. We sort of friendly rivalry about that, but I think I'm speaking the truth as of last week that
you guys are winning.
We're winning.
I like that.
Yeah.
I like that.
So our patients are winning. I mean, we take it personally that we're, but not everybody has been coming in these days for screening, and we noticed our numbers dipped a little bit. We're bringing them back up this year, but in the 2 years previous, kind of dipped.
I'm sure. And that leads me to this next question for you. So as a layperson, I want to understand from you, I take my car in for maintenance, right, at regular intervals. And I change the oil like every 5,000 miles, or doing a 2,500 mile checkup, on the whole thing. So when it comes to our bodies, can I run through a quick checklist with you, and I'll give you the age range, and then you tell me and our listeners what we should be doing? Okay. Are you ready? I hope you win.
I'll come close.
Okay. What screening should we be getting in our 20s and 30s?
Yeah, that starts. We'll start even earlier. From the time you're a baby, we'll be checking your hearing, and when in your 20s and 30s, we check for sexually transmitted diseases. It's a real common one that we do for people. Obviously, for people who are sexually active, but that then in their mid 20s, women will generally start to have Pap smears. And now the Pap smear is not just for detection of abnormal cells, but now we check for HPV, which is human papillomavirus. And so so that's pretty common. Blood pressure, we like to find out if there's an early trend towards somebody having hypertension, because that's something that can be intervened in an early phase. So those are the kind of STD testing, and I say that on Pap smears and hypertension screening are probably the most common things for 20s.
All right, so now we're moving into our 40s. What do we do?
So during the 40s and throughout lifetime, we're going to be screening for hypertension, because that may be an insidious onset type of thing. So we'll always screen for hypertension. But for a woman beginning in her 40s, again, a little bit depending on family history, we'll start doing mammogram screening for breast cancer. Cervical cancer screening continues on for women throughout their 40s. And in the 40s is when colon cancer screening comes into play. Depending on your family history or particular backgrounds, we may start as early as 40, even younger, but typically by 45, we'll start screening for colon cancer in everybody. So then somewhere around there, we'll start to screen for cholesterol. There's some controversy about how early that ought to be done, but it's pretty well known that particularly in men, they can start to develop atherosclerosis at pretty young age, particularly if they smoke. And I probably should mention that smoking cessation is not really a screening, so to speak, but it's part of what we try to intervene on. But so if somebody is showing signs of high cholesterol in their 40s, that's going to put them at a higher risk for heart disease, and there are interventions for that. The cholesterol-lowering drugs may be started in somebody in the age group of their 40s. Glaucoma screening is done around that time, so we try to have people see an optometrist or ophthalmologist for glaucoma screening, elevated eye pressures. the diabetes is more common now than it used to be because of obesity. With the kind of obesity epidemic that we're seeing, there's many more patients that develop diabetes in their 40s, and so we screen for that, and not because not everybody knows they have it. It can be subtle, and untreated diabetes, if it's untreated over long term, can cause difficulty with eye problems, blindness, kidney failure, early heart disease. So we start screening for diabetes in patients in their 40s.
So all of that in your 40s. So we better get
Gets
started
busier.
if we're in our 40s.
Gets busier.
Now let's move. Does it get worse or better? What about the 50s?
Well, it's still more of the same. Cervical,
Okay.
colon, breast cancer screening. It's really a lot more of the same. By 50s, though, patients may have smoked long enough that they've put themselves at risk of developing lung cancer. So there's now programs using CT scans on an annual basis for people who have a certain number of pack years of smoking. And so the concept there is to try to, it's not really preventing lung cancer. It's not happening, but the idea there is to try to detect lung cancer at stage 1 before it's spread, and it can be surgically treated, fairly low intervention, so less destructive to the patient's lungs if it can be detected sooner. So lung cancer screening is something that's been started probably in the last 5 years. It comes into play probably more in patients in their 50s and 60s. So.
And then 60s and onward.
So for men and in their mid 50s, around 55, but this again depends on, there's certain populations, if they have a family history, African American descent, will start prostate cancer screening sooner. But around 55, typically for men, we'll start annual testing for prostate cancer with PSA, prostate-specific antigen testing. So that starts up.
In 60s and 70s, it seems like you get a little bit of a break. You don't have to go in quite as much.
Well, that's okay. So that's an interesting kind of concept. So prostate cancer screening generally is thought to be best done between age 55 and 75. The older the man is, the less likely they are going to die from prostate cancer, more likely to die from some other cause. But as far as breast cancer screening, and colon cancer screening, generally it's recommended to be done to age 75. But I think that a lot of us will really individualize that after 75. One is to see how healthy is the patient just in general. I mean, if they're likely to live many more years, and we see many patients live into their 90s now routinely. Amazing. Now, there's another thing that starts to, I don't think that this is probably a standard recommended screening test, but a lot of us do it here, which is what is a test called coronary artery calcium CT score. And what that test is about is it's a CT scan done through the levels of the heart that measures the amount of calcification in the walls of the coronary arteries. And the computer scores it from 0 to 2,000 or something like that. And so it's in men and in women. Women develop this a little bit later because they have estrogen protection. So they generally develop heart disease a little bit later in their life. But somewhere in men between 50 and 60, women maybe 55, 65, somewhere in the time frame where you could make an intervention. I'll get to that in a minute. But a lot of us will, particularly if a person, well, I think especially if a person has a high cholesterol baseline, you can do this coronary calcium test and you get a score. And if you get the score of 0, which is fantastic, you're all kind of reassured that it's a wonderful thing. And if you happen to get the occasional surprise of somebody very high, that person may be at particularly high risk of heart attack, and you might refer them to cardiology for further stress testing or so forth to try to make sure they're not imminently going to have a heart attack.
And let's move to another arena. What about the importance of screening for mental health?
Yeah, so that's I'm glad you asked about that because the impact of COVID, particularly on young people, being not in their regular school, not their social lives have been disrupted. I mean, I can't tell you how many young women were crying about not being able to go to prom. My son couldn't walk his UCLA graduation. They're stuck at home with parents like me for 2 years. God help them that they make it through it, and it has had a very bad impact. Not just we see it, adults higher risk of drug and alcohol use, and kids has been a much higher incidence of depression, drug overdoses, and suicides. I mean, so we have, as part of our screening, every patient that comes in at least once a year, and we mostly do it almost every visit, we screen them for depression. If we identify somebody who's depressed or anxious, not psychotic, but for most people who have depression, sadness, anxiety, that is felt to be able to be treated in a primary care setting, we can initiate the treatment, we being family doctors or internists or pediatricians for that matter. So we can initiate the treatment, and then we refer them into our collaborative care program. So we have a number of social workers who then will kind of, glom on to the patient, because a lot of times these patients you might prescribe something, then you lose them. They don't come back. But the social workers, they get attached. And so they'll call them regularly, find out how they're doing, take a more of a history. Then we have a psychiatrist embedded in the program who's he's not seeing patients, but what he's doing is he's reviewing my notes, the social worker's history. We have a medical director, and they will then help me kind of adjust and improve the therapeutic plan. And then some of them do therapy. Some of them will then refer into the patient's mental health network, but they help guide them into that so they don't get lost. So this program's been very successful, and we're really trying to have a 0 suicide. I mean, we'd like to have a 0 colon cancer, 0 cervical cancer, 0 breast cancer. That can't be done, but we're really trying to identify and help anybody who's having any suicidality and depression. And so this program spread into I think we have now 5 different ones. One's going in peds, OB, oncology, and the big primary care group. So
wonderful.
That's that
great.
one. And we're hoping to bring those numbers down.
Yes. What other barriers would you see keeping people from going in to get their regular screenings?
I ask patients. I ask patients that a lot. Some of them are afraid of. My wife will tell me that mammograms are not particularly comfortable. I can understand that sentiment. So there may be a little bit of a reluctance to have your breast compressed between the blades, like the cold, that happens. So I think there's that. I think a lot of people don't want to do the colonoscopy prep. I mean, I just did mine in December, and I'd have to go every 5 years because my dad was saved from colon cancer death by having a colonoscopy. So I have to go every 5 years, and it seems like those 5 years go quicker and quicker until I'm drinking that Miralax stuff. And so a lot of people don't like that. So I'm kind of glad we have a little alternative stool testing kit for the colonoscopy chickens. But I don't think it's so much expense. I mean, because with the Affordable Care Act, preventive health things like mammograms and colonoscopies generally are covered, and Pap smears, HPV screening, STD testing, that's pretty much all covered. I think there's some a little bit of fear. I think it's kind of somewhat laziness. I mean, it's probably for the same people who maybe don't change the oil in their car regularly. It's they don't kind of think. Younger people, they they typically feel like they're invincible from stuff, and so they that's why we tend to try to get them to at least have a relationship with a primary care physician. This is something, I mean, so for example, in urgent care, I've done this now 37 years or something like that in urgent care. And so a lot of patients are unattached. And so they might be there because they flipped off their scooter, but you start talking to them and find out that, oh yeah, hey, your blood pressure's kind of high. Oh yeah, that runs in my family. I go, yeah, I work here on the third floor. If you want to come in, to kind of establish a relationship. So we capture patients out of urgent care and try to get them together. And one of the things I think that's going to help the cause is virtual visits. Now that was hardly done at all until March of 2020. And then lockdowns happened. And I think within 48 hours, the St. John's IT department had us up with Zoom visits with patients. And they were, in general, once they figured out how to turn the audio on, and we figured out the camera, but once we figured it out, people were thrilled with that. And I've had patients say, "I'm never coming in to see you again." I go, well, yeah, maybe, but the idea is that now I have a kind of a way to stay in touch with people who maybe live in the San Fernando Valley, or they've moved down to Del Mar or something like that, but they still may want to have a relationship with me. I keep track of all their stuff. I can do a lot of those things remotely anyway. Yeah. They can do their blood pressure monitoring at home. They can go get their cholesterol checked at a LabCorp in Del Mar if they want to. I can send orders for mammograms and so forth to other places. So if they stay in touch with a primary care physician longitudinally, I think it works out.
Yeah, you're making it much more convenient for them. We're going to shift gears a little bit and move to vaccinations. So tell me about vaccinations as part of preventative care.
I'm glad to ask about that. We think of in family medicine, primary care. Family medicine is we take care of adults and kids. Internists take care of adults. Pediatricians take care of kids. But we're all in it together. OBGYNs too. We're all in a team. We're all team effort on this. But so I mentioned my grandfather. So he practiced in the era where antibiotics came on, but that was not what impressed him as to be the game changer. The game changer to him was immunizations, and he. I mean, if you imagine to somebody practicing, 23 was he graduated, so that was just after the flu epidemic of 1917, and he wasn't a physician during that time, but he's volunteering in hospital. I mean, I know many stories of him telling me about that. So would be highly impressed by what happened with so many people dying then, and then it was more young people than it is from COVID. Has been older people mostly have been dying, but then he has seen smallpox, but what really he was feared in the 40s and the 50s was polio.
Yes.
And he told me he thought that Salk and Sabin, who invented the two polio vaccines, were really saints. I mean, he said that changed so much, especially for somebody who loved kids. Childhood vaccinations was just, he said, absolute game changer. Now his practice was different. It's right out of Norman Rockwell, and the one it was in his house. It was one room in his house. My grandmother was the nurse. I mean, my his entire records of a patient would be on a 5x7 note card in a shoebox. Okay, so can you imagine that? Looking at a whole lifetime record, the electronic medical record is just a blowout of information. But what he kept track of was their measles shots, their mumps shot, rubella shot. So even in my life, my practice lifetime, starting in the early '80s, I think that we used to give kids maybe 7, 8, 10 shots, something like that. But now I think it's 25. It's some are combined, but it's miraculous. Polio has basically been eradicated. Smallpox is eradicated. We rarely, fortunately, see measles, germa measles, but even things like childhood pneumonias, ear infections, bacterial ear infections, meningitis, stuff that we used to see regularly in my pediatric training, is extremely rare. I mean, looking across the street over here to St. John's, we don't even have a pediatric ward anymore. I mean, there's one over at UCLA, but the reason for that is that those wards used to be primarily filled with infectious disease cases. But now those are mostly handled as outpatients, but are so much less prevalent. And so that you take the childhood vaccinations and then go into adolescence, and the HPV vaccine now that goes up all the way now to age 46 for patients that can get HPV vaccine up to age 46, which is something fairly new. Because HPV not only causes cervical cancer, causes oral cancer. And so it's a good vaccine for all young people to get. And then in the adult vaccine world, we give pneumonia vaccine, and there's about many strains. I saw pneumococcal pneumonia all the time in med school. We never see that anymore. Worldwide, that's been the case. Chickenpox vaccine we give to kids, but now, sort of because of that, it used to be once we had chickenpox and you're susceptible to getting the re-onset of it as shingles as adults, and so now there's a very effective vaccine against shingles, and then usually I can now you tell patients, you probably know somebody who's had shingles, right? Oh yeah, it was terrible. Oh, how about you get the shingles vaccine? Oh yeah, I probably should do that. And we track that, and we keep reminding them to do it.
Well, there are new types of screenings that I wanted to talk to you about. And something that's gaining popularity is the blood test to see about your possibility of cancer. So what are your thoughts on that? And in what cases would you recommend someone getting that?
Yeah, this is so well. I think you were talking earlier about PSA. So PSA is a blood screening test, and it's not our best screening test. It's what we have. It's not perfect by far, but it's what we have. But what's coming next, I think, and is coming along, is more genetic type blood screenings. So I think we all know that you can send away to 23andMe or Ancestry.com. You can get your whole human genome analyzed. I mean, it's phenomenal technology. There are certain genes that are useful to know if you have it. Say, for example, a woman who might have a family history of breast cancer, she may be a good candidate to be tested for the BRCA gene. And if you know that the woman has a BRCA mutation, then we know she's going to be at more at risk for breast and ovarian cancer. And there are interventions to be had. Certainly a woman who is, past childbearing age, who's BRCA positive, probably should have her ovaries removed. And we would be screening that woman much more regularly for breast cancer, both with ultrasound, mammograms, and MRIs. So we know kind of what to do with BRCA as best we can. There was some years back, very talented comedian Gilda Radner was on Saturday Night Live. She died of ovarian cancer at a young age. And so there was kind of a move to see if it could be possible to use a blood gene test called CA-125, which is, I guess, in a way similar to the way PSA it would be used. It's a marker for ovarian cancer, and its primary use is to detect recurrence of ovarian cancer after a woman has been diagnosed and, say, treated. You can monitor that level. But it was thought that, well, if you can monitor after having cancer, why not just screen for it? And so that started to be done very widely. And what happened with that is that there's when you screen a lot of women in a population where the prevalence of ovarian cancer, fortunately, is very low, what you end up with is finding a lot of women with an elevated CA-125. And then you would be obligated to say, well, okay, so we better do an ultrasound and look and see if there's any cancer. And usually there wasn't. And so it created a huge dilemma that most women who had an elevated CA-125 never got ovarian cancer. But it's extremely anxiety provoking for a woman in that situation to think, well, what does that mean? Should I have my ovaries removed even though there's nothing obviously wrong with them because I have an elevated marker? So that one at this point sort of not done. And we certainly don't encourage it. And I think these things might introduce a lot of extra fear in people when we don't just know yet exactly what to do. Like, we know what to do when a woman has positive HPV on her pap smear and she has abnormal cells on her cervix. We know that we can do what's called a LEAP procedure to sort of skive off the last few millimeters of the cervix where those precancerous cells are. And we know that that's going to be probably curative to preventing further cervical cancer. Mammogram, similar. Colon cancer, we really know what to do with that. When I have the same precancerous polyps my dad has. I'm not dying from colon cancer because my polyps get whacked out every 5 years. That's not, nobody gets out alive, but I'm not going that way.
Yeah. And
so we know specifically what to do with those things. We don't yet know what to do with some of the genetic ones, but my daughter will graduate from med school next year, 100 years after my grandfather. And what will the course of her career will be different.
That's right.
It won't be antibiotics and immunizations. It'll be something different, but, be fun for her to find out.
Yeah. And what a beautiful way to lead us into my last question. And that was, who you come from a long line of family doctors. And you had said earlier in our interview that your father was a big inspiration for you. And is he the one that inspired you to become a doctor?
Well, it was my grandfather.
Your grandfather.
My grandfather. That's right. My dad sold beryllium, and he ran from doctors as much as he could, but he couldn't get far because I'm a physician and my wife's a family doctor, Dr. McGrath, and she loved my dad and talked him into getting a colonoscopy, and he lived a long life to 87 and did not die from colon cancer, and so It was my grandfather though kind of inspired me, and so that was, yeah. He practiced 50 years.
Wow.
And so this is my 41st, so I'm trying to make it to
You're
50
catching up.
here at St.
Yeah.
John's.
So if you have one last message for our listeners regarding preventative care, what would it be? Sum it up for us.
Find a primary care doctor you like and stay with her or him, and they'll take good care of you and guide your health.
It's great. It's so, so true. Well, unfortunately, we have come to the end of our show. It was wonderful having you here with me, Dr. Needham, and I got so much great information from you. And thank you to St. John's Health Center Foundation for making this possible. And thank you to all of you for watching and listening. Until next time, I'm Kim Douglas with your Healthy Dose.